Greetings, everybody. Thank you so much for joining us. My name is Erica D'Agostino. I am the Senior Executive Director for the Arthritis Foundation, and I'm happy to welcome you to this, our fourth annual webinar series in conjunction with the Disabled American Veterans. And this topic tonight is on spinal osteoarthritis. So welcome to you all. We have an incredible panel, and we're excited to get started. As we begin, just a couple of housekeeping things. All attendees are automatically muted and kept from coming on camera. This is just to make sure that the flow of dialogue continues unabated. We will have a discussion and then a Q&A at the end. If you have questions, we highly encourage you to place them in the chat. We will be looking at them throughout and then getting them together for our panelists to respond to at the end of the overall discussion. There will be a post-event survey that we really encourage you to fill out. That survey will also come with some incredible tools and resources for you and places for you to look and search out additional information. In addition, we will be posting this webinar in its entirety to our YouTube page, and then as well under our webinars page on our website. We also have a special arthritis.org/military website that this will additionally get posted to. I am excited to introduce our moderator for the evening. He is an incredible champion to the arthritis community, as well to people with arthritis here at the Arthritis Foundation. Commissioner Rob Santiago of the City of Boston, who is the head of the Veterans Services Department. Rob has spent 20 years in the Navy and retired here in Boston. He is on the executive board of the Massachusetts Veterans Services Officers Association, and he's a life member of the DAV, the VFW, and the American Legion. I also want to specifically shout out that Rob is a member of our Massachusetts Local Leadership Board, and he chairs our Military Veteran Services Subcommittee. So without further ado, Rob.
Thank you, Erica, for that wonderful introduction. It's great to be here again today, and I'm excited to once again serve as a moderator. So I want to welcome everyone. We are so thrilled to have you here tonight joining us for our fourth annual Arthritis in the Military Roundtable webinar. Tonight's discussion is going to include an expert panel to include Dr. Krishna Normel, Laura LaPala, and Coleman Nee. As many of us know, arthritis is the #1 cause of disability in the United States, but arthritis disproportionately affects people in the military. In the general civilian population, the average rate of arthritis is 1 in 4, but in the military, that increases to 1 in 3, or just a little over 34%. Osteoarthritis is the most frequent reason that active duty personnel can be deemed unfit for service. And for wounded service members, they often require costly lifelong care for this progressively degenerative condition. Service members injured by roadside bombs and other blasts are often diagnosed with the condition after within 2 years of being injured, versus civilian injuries where the onset of arthritis usually occurs around 10 years or later. But tonight our focus is going to be on uncovering the puzzle of spinal osteoarthritis for the military and the veterans community. Our first panelist tonight is going to be Dr. Krishna Normel, who is an experienced, caring, empathetic, and thoughtful neurosurgeon in Natick, Massachusetts. He listens to his patients and thoroughly analyzes the clinical, radiographic, and examination data and explains them to the patient. He educates them regarding their condition and offers valid clinical choices in treatment. He has patience with his patients' questions and gives them clear and comprehensive information to help them make the correct choice of treatment. Through his practice of minimally invasive surgery, blood loss, scar formation, and complications are minimized, enhancing a quicker recovery from surgery. He is currently licensed to practice medicine in Massachusetts, and he is affiliated with Metro West Medical Center in Natick and Framingham. Dr. Normel speaks English, French, and Hindi. Dr. Normel, welcome.
Hi. So what I want to do is perhaps first talk about what osteoarthritis is. It's defined as a condition and a disease state, but really speaking, it's a condition that occurs in everybody as they age. And as was just pointed out, when people are exposed to multiple traumas or injuries, they tend to develop the arthritic changes in their spine as well as in their joints much earlier. And this obviously applies to people who are in the service, and part of it being the high amount of weight they carry in terms of their backpacks, and the kinds of duty and activities they have to do. It's particularly a problem in people who are parachute jumpers, etc. So again, a lot of it is relevant in terms of the trauma. In the civilian population, we see that often in athletics where there is contact kind of sports, such as football, that these players end up becoming patients at a much younger age. And when you become a patient, it's because there are symptoms. And the key symptom that patients complain about are that they have stiffness when they wake up in the morning, or when they bend, when they try to straighten out. It's a chronic kind of a pain that persists. Many times you sort of accept that it's just getting old. And generally speaking, most patients do not seek treatment unless the symptoms become significant. Most patients end up treating themselves with Tylenol or a medication like Advil or something to try to alleviate their symptoms. So generally speaking, the symptoms are worse in the morning when you wake up. And one would say, well, gee, I've been resting for 8 hours. Why am I sore when I wake up? It's just like your car engine when it is cold. It needs to start a little bit slowly, and then gradually it gets oiled and gets better. The same thing happens with arthritic patients and arthritic joints. Things are a little bit more difficult when you first wake up. As you do some stretching, walking around, symptoms generally tend to get better. So this is an example of the normal spine. So this is the front of the spine. This is the back of the spine. And this is what you feel when you touch yourself at the back of your neck or the back of your lower back area. And the spine basically has two key kinds of openings. One in the center, which is called the spinal canal, where the spinal cord and the nerves run down from the brain all the way down. And then at the side are these openings where the nerve roots come out. And these openings are called foramen singular or foramina plural. So the canal in the center, which is right here, and then the nerve roots come out on the side. So it's somewhat like looking at your highway. The highway is your central canal, and then these openings are like your exits, each one going to a different destination, different part of your body. So this shows you where the disc is healthy, and it has got a certain height in there because it has got good water content. As we age, the water content decreases, the disc becomes more fragile. The disc is basically like a radial glide tire. It's got a very tough outside coating, something like in your cushion. And the central part is softer, which is the actual nucleus of the disc. The outside part is called the annulus. So this is a healthy looking disc. So you can see these joints are healthy. The disc is healthy. Here, with time, the disc has degenerated and people develop bone spurs. And these bone spurs happen in the front, doesn't cause much problem, but when they happen in the back, inside the canal or at the area of the foramen, that's where the compression of the nerve happens, and that's where the pain comes from also. So the pain is partly because there is arthritic joint, so it doesn't move as well, but also because the bone spur is now compressing the nerves. Next slide, please. So this is just a magnified view to show you how things would look. This disc looks healthy. Again, this is the front, this is the back. But here you got arthritis in the joint, and you can see it starts encroaching on that opening where the nerve root is coming out. And the other reason why the nerve gets compressed is because the disc loses height, so that this opening gets smaller. So the foramen gets smaller, or it gets compressed by the bony spur. Next slide, please. Okay, so before I go to surgical interventions, just let me talk briefly. Actually, let me just stop here to see if there is anything else that you'd like me to explain.
Yeah, doctor, one quick question. You mentioned earlier that sometimes the patient doesn't know, that they have this. So what in your estimation is the average length of time between a patient sharing their concerns with their PCPs about their pain to when they actually end up thinking, about having any type of surgery.
Right. So as I said, we find that most times it is probably going to be in the range of 5 to 10 years before the patient actually ends up with a specialist. In between, they may go to their primary care doctor, and initially they would prescribe some medication, such as an anti-inflammatory medication like Advil or something. And generally speaking, I would say 99% of the time, the patient is referred for physical therapy, which I know we're going to talk about later. These are the conservative treatments that one does. And really speaking, the patient ends up with a specialist only if the symptoms persist significantly, or they tend to get the pain so badly that they need to go on narcotics, or they develop significant impairment in the day-to-day living activities. For example, taking a bath, taking a shower, getting in and out of bed, etc. Or if they develop a neurological deficit, meaning a weakness or numbness in one of the limbs.
Thank you. And just to remind everybody, if you have any questions, please put them in the chat, and we will do everything that we can to get to them at the Q&A session of our discussion this evening.
Okay, so one other thing I want to mention here before we go to surgery is that generally speaking, medications, physical therapy, massage, etc., are tried initially. If that helps the patient, more often than not, the patient does not need to do anything further. Then there is the in-between step, which is where pain management comes in. And what pain management tries to do is to do small interventions without doing surgery to try to help the pain. And some of the things we do in pain management would be to give the patient an injection of steroids in the lower back or in the neck area. Steroids, as you know, are powerful anti-inflammatory drugs, and therefore they will reduce pain. Now, many times the patient's primary care doctor may even suggest a short course of oral steroids, which is by mouth, in a tapering dose over a period of 7 days or so. And that will help with the acute symptoms, but clearly you cannot stay on steroids for a long time because of the side effects of the steroids. So the advantage of the epidural steroid is that it's a much smaller dose that is injected in the spine. It's an outpatient procedure. It's done under local anesthetic, and usually takes about 10-15 minutes, and the patient's able to function as they were when they walked in. So that's the in-between step that many patients will go through, and that may take anywhere from 2 to 5 years, again, before patient comes up for surgery. So next slide, please. Okay, so the patient comes for surgery, as I mentioned, because they have significant impairment in the activities of daily living. They're impaired in terms of doing what they're doing, or they're requiring narcotics because the pain is significant, and they failed all the conservative treatments such as physical therapy, injections, medications, etc. And the reason for surgery is usually twofold. One is because there is what's called spinal stenosis in the canal. That's the part, as I mentioned, this is the canal in the back here. And so what happens is, as the disc loses height, as the joints grow in, the canal gets smaller and smaller. And as the canal gets smaller, it compresses the nerves, which of course causes pain. It's just like if you can imagine squeezing your lung and squeezing your chest, your heart is not going to feel good, or your lung isn't going to feel good. And remember, this is a bony canal, so it cannot get bigger. Your chest can actually get bigger, but the canal cannot get bigger. If anything, it continues to get smaller. So spinal stenosis simply means narrowing of the spinal canal, and that causes compression of the nerves. Also, remember, there are small blood vessels on the nerves themselves. So as the stenosis progresses, they get choked off, and that's why people become symptomatic and start losing neurological function. The other reason for doing surgery is that many times as the joints degenerate over time, that there's a slippage of the bones, or what's called listhesis. And if you can imagine, the spine is basically a set of rings. You can see that, okay, set of rings. So when you have the rings correctly aligned, there's a patent opening, but you put them eccentric like that because of slippage, you create stenosis. Now, that may be something that is stationary, meaning the slippage, or then it's called stable, or it can be unstable, meaning the bones move back and forth. Because the disc has lost its height, and the joint no longer has the same kind of cartilage as there was. So that is the other reason why patients end up needing surgery, because there is listhesis that's causing compression of the nerves. And this is somewhat like if you can imagine your door with 3 hinges, the hinges wear out, you can still use the door, but it sort of is loose. So that's what happens in the spine. So two key reasons why we do that is the spinal stenosis, which becomes significantly symptomatic after failure of conservative management and treatments that we talked about, or if there is slippage, which is causing the patient's symptoms because of the problem it creates in terms of compressing the nerves. So one of the things that we do is what's called a decompressive laminectomy. So the back part of the bone here is the lamina, which is removed at the time of surgery. And the idea being that if the canal is too tight, you want to open it up. So instead of it being an O-shaped canal, it becomes a U-shaped canal. So part of this bone and the lamina is removed. Also, because of the arthritis in the joints, part of the joint is removed. And this joint is called a facet joint, and the procedure is called facetectomy. So when you do all that on both sides, you essentially have opened up the canal and opened up the area where the nerve roots are going. But you removed bone. You were given all that bone for a reason. So by removing the bone, you are actually potentially creating an instability in the spine. And because of that instability, you go through what's called a fusion. And the common technique that is used is to basically fuse these bones together. The idea being that then there will not be abnormal motion and they will not slip because the bone has been resected in the back. Now, there are several kinds of fusions that are done, and they can be done with an open operation, it can be done with a microscope, or it can be done with what's called minimally invasive surgery. The idea about MIS, or minimally invasive surgery, is that you reduce the trauma. So part of what is done, and I'll show you some pictures later, is that the surgery is done by small holes, and then you put a guide wire in the bone, and then you put what's called the working channel. And then everything is done through the channel. So you're not disrupting the muscle, and muscle, as you know, is fiber. So you separate it out. At the end, you pull out your working channel and the muscle comes back together. Much less bleeding, much less trauma to the tissue, much less scarring, and therefore much less pain in recovery and faster recovery. So this is an example of the fusion, which is done from the back. A screw is put into the bone through the pedicle, and this is why it's called a pedicle screw. This part of your bone is the strongest part of the bone, and that's where the screw goes through. This is the vertebral body, so the screw ends up in the vertebral body. The head of the screw is out at the back. It's like a tulip. And so what is done is once you put the screws in position, you can distract the spine, i.e. separate out the bones, or you can compress it if need be. And what is also done is the disc has lost height, as I mentioned, when it degenerates. So a substitute is put in, which is called an interbody spacer. Now, this interbody spacer can be made of metal, which is titanium, which is often used, or it can be a synthetic equivalent to bone, which is called PEEK, P-E-E-K. It is a synthetic material, which is like bone. It can be bone donated by somebody from their cadaver, which is allograft. And people have stopped using autograft, which is the person's own bone, which is taken from the hip area or the iliac bone area. So you put those interbody devices, and then you stabilize this by putting the rod in the back. And these are tightened down to appropriate torque tension. And these patients are usually able to get up the same day or the next day. And in the majority of the cases, if they do okay by the next day, 24 hours after surgery, they can go home. Sometimes the patient may stay 1 day extra. And infrequently, when somebody's very disabled or elderly, they may go to short-term rehabilitation. Next slide, please.
Oh, doctor, I have a quick question that came in. If someone gets a spinal fusion, how likely is it that they will need an additional fusion to the joint above or below that original fusion?
It's a very good question. And it is something that is explained to the patient. So what happens is that when you, on this slide, for example, I'll show you, when you stabilize these 3 bones here, what you've done is you created one single bone then. So if you remember, there's a single bone that moves on top of each other. So now what you've done is you loaded up the tension at the top because these three bones will not move. They are fused. So this joint here is more likely than not to potentially cause a problem at a somewhat greater rate than by natural degeneration. In other words, what happens is that even if the patient did not have fusion and there was stenosis here, in time they are going to get degeneration of the joint above and above, etc. But it is believed that by doing the surgery, because you fuse these as a single mass, that there is more degeneration at the joint above typically. The joint below, not so much, but can be also. And this is known as adjacent segment degeneration. Happens both in the neck and in the lower back.
And doctor, can you also quickly talk about some other surgical options that are available for spinal osteoarthritis?
The other kinds of surgeries, yes. So next slide, please. Okay, so this is an approach where the spine is approached from the front. And this approach is favored by some surgeons. And sometimes we use that when the patient has previously had multiple back operations, because then going back into the back through the scar tissue creates more problems and more potential risk. The disadvantage of the front approach is obviously you have to approach it through the abdomen or the belly. And so you need what's called an access surgeon who allows you to get access to the area in front of the spine. In front of the spine is your aorta, which is the major blood vessel that is taking blood from your heart to your legs and bringing it back. And also next to it is also what's called your inferior vena cava, which is a large vein that's bringing blood back to the heart. So there is significant potential risk that you could injure these structures, and which is why you need an access surgeon to help you. There are some surgeons who feel comfortable, they may do it themselves, but the majority use an access surgeon. There's also the risk by this approach that there could be injury to the bowel or the ureters. So oftentimes they will actually catheterize the ureter so that they can feel it, and there's less chance of a risk of having any injury to those structures. So these are two different kinds of models which show how there's the interbody device that is put in, and then a plate which screws on top to secure it so it doesn't pop out. This is unified. This is the PEEK implant, which is the interbody device, and there are screws which are aligned at the top, which is fixated to the interbody device, and those are put in place. Next slide, please. Okay, so and sometimes what happens is that you may need to have surgery from the front and the back, depending on the kind of slippage you may have, or if you've had previous surgery to correct that. One of the other things I just want to briefly mention is osteoarthritis and sacroiliac joint or SI joint dysfunction. About 26% of patients with low back pain have significant problem with their SI joint. And so it was something that maybe 20 years ago we didn't really address, but now people are more aware of it and it is addressed. So again, the treatment for this arthritis affects your sacroiliac joint. The treatment for this is first conservative, physical therapy, etc. That doesn't work, you can give steroid injections at the joint, in the SI joint. And if that doesn't work and the symptoms are significant and the patient's disabled, then you do what's called a sacroiliac joint fusion. So there are a number of different devices there. And you will ask, well, how much does my SI joint really move? So in a male, the SI joint will move 1 to 3 millimeters. It's not a big motion. And in females, it will go up to 5 millimeters. And part of the reason is that the anatomy is built so that the fetus can reside in this area. So there is a greater degree of motion that is allowed at the SI joint in females as opposed to males. So when the treatment is offered, which is of the sacroiliac joint fusion, is that typically there are 3 implants placed at that joint. Usually we end up doing one side. Occasionally you may end up needing to do both sides. One of the other things that happens is that the lowest part of your spine in the lumbar region or the low back is L5, and below that is your sacrum or S1. So this is L5 and this is S1. Sacrum is otherwise a fused set of bones here. So what happens is if you have a fusion from sacrum to say L2 or L3, over time, The next joint that will get affected, as you were asking about before, is the sacroiliac joint. So sometimes patients who have a lumbar fusion, after a few years, may end up needing a sacroiliac joint fusion because of the degeneration. This is just a side view of the sacrum to show you how these implants are put in. This is all done through little incisions through a tube. And again, this is done with an MIS mechanism so that there's much less bleeding. These patients are able to go home the same day or the next day, usually. Okay, next slide, please. All right, so switching sites, unless there was any specific issues you wanted me to discuss on the lumbar. No, okay. So in the neck, you can develop similar kinds of symptoms. Again, this is obviously the front of the neck. This is the back of the neck. This is the spinous processes. And here's the vertebral body, disc, etc. So in the neck, there are 7 bones, and this is called the cervical spine. So this is C1 all the way down to C7. C1, C2 is a unique joint where you get 50% of your rotational motion in your neck, etc., and there is no disc there. So the discs exist from C2 down to C7. Now, remember, the discs are not numbered. So the way you identify a disc, you say it's between C2 and C3, C3, C4, etc. So whenever you refer to a disc, it is 2 numbers. Again, the same thing here. You first try medications, conservative treatments, try injections. Only if all of that fails, the pain is significant, or there's a neurological deficit, then you consider surgical intervention. There's 2 ways, again, you can approach this. One is from the front. So what is done is that you come in from the front, through the front of your neck, remove the disc, remove the bone spurs, clean up the area here, and then again, to prevent the disc from collapsing, you put in an interbody. This is an interbody with some bone graft in there. And then to secure it so it doesn't pop out, you put the plate with the screws on it, as you can see here. And there is a safety mechanism built into this so that these screws are covered so they cannot pop out, because that was one of the problems that sometimes used to happen. And again, these patients, the operation takes about, for a single disc, about 2 hours or so, and you can go home the same day or the next day. And generally speaking, there is not much of a loss in terms of range of motion or something, because I'm sure somebody's wondering, well, if you fuse my disc or my bones, am I not going to lose range of motion? So typically, one would say it's about 7 to 8 degrees range of motion, but it's a wash. Wash meaning with the fixation of your spine, the pain gets better, so you have better motion. Whereas before there was arthritis, and because of the pain, you were limited in your motion. So many times patients do not notice any significant change in the range of motion with 1 or 2 discs, which are repaired this way. Next slide, please.
Oh, so doctor, really quick. So you're talking about the patients going back home the same day. So can you talk a little bit about how technology has impacted the surgeries and recovery times and the advancements that have been made within recent years?
Sure. Okay, so there's several things that have changed how things are done. One, of course, is the fact that we are now doing surgery with what's called minimally invasive surgery. So the incisions are smaller, blood loss is minimized, and there's much less tissue trauma. It's the tissue trauma and especially the muscles that cause the pain. So by using the MIS technique, we have minimized a lot of this. The devices have become more streamlined, and people are more used to do things over a guide wire. So you work through small tubes. The other thing that has happened is that you can add microsurgery with the surgery so that you're doing the surgery with a microscope. And generally speaking, neurosurgeons prefer to use the microscope. Orthopedic surgeons who also do spine surgery do not usually use a microscope. What a microscope allows you to do is that you can magnify objects, and the microscope has what's called a pure white light. So it's not a yellow light, but a white light that you can see things clearly. Because of the fact that you're using a microscope and you magnify things, your instrument that you use in there is smaller, the amount of manipulation you do is lesser. So this is another aspect of how technology has improved the fact that patients can be treated and go home a lot quicker. And I can talk briefly about the fact that The other advances that have happened is that now we use a spine robot, and it's not a human being kind of a thing which moves around, but basically what it is an arm attached to the machine that will direct you to the specific location. And you can do this in real time so that you can see how the screw is going to go, where it is going to go, etc. That speeds up the process. So shorter surgery, quicker recovery.
Thank you, doctor.
Okay, so now let me just go to this. Go back, please. Previous. Okay, so this is just to show you that the other advance that has been made is that we can now use an artificial disc. So this is an artificial disc in the neck from the front. So instead of fusing, as you can see, it is just this one device. No screws here, no plate here. And during the time of the Iraq War, there were many young veterans who were coming in with injuries in their neck related to disc problem. And so at that time, people started doing 2 discs at the same time. Before that, the disc was only cleared for a single level. If somebody had 2 ruptured discs, they would end up having 1 fusion, 1 artificial disc. But since that time, we are now able to do 2 artificial discs at the same time. The surgical technique approach is all very similar. This takes a little bit of time because, as you can see, you want to fit it exactly in the correct position. And what this allows the patient to do is that they can have all the range of motion that they had before. They can bend, flex and extend, rotate, and also side to side. So this device is built so there is a metallic component at the top and bottom, and inside the center is a little spherical ball, and that allows the motion. So this is the other advance in that in a younger patient, one could do an artificial disc. And as I said, we can do up to 2 discs at a time. Next slide, please.
Okay, doctor, thank you very much. Before we move on, do you have any more final thoughts on all the great work that you do?
I'll try to think. I don't know if you wanted me to talk briefly about complications.
Oh, yes, please do. Please do. I just would like you to, when you're done with your slide to.
So one of the things that obviously everybody has in mind, I mean, I can tell you about the fantastic surgery we do, how great it is, but what are the risks? So there are 3 kinds of risks one looks at. One, of course, is when you open skin or when you cut skin. Anytime you cut skin, there's a risk of infection. There's a risk of bleeding. So we minimize this, as I told you, by using the technique of microsurgery, minimally invasive surgery, etc. If there is significant bleeding, if there's an infection, the patient will need antibiotics or take the blood clot out. Also, remember, we're working right on the spinal sac, which contains spinal fluid. And as you know, any tissue that is compressed for a long period of time thins out. So the dura, or the membrane, is attenuated or thinned. So there is a greater risk of having a tear in there. And that is something that can be a complication too. Usually it is repaired and the repair works perfectly fine. So these are sort of standard risks, whether you go from the front or the back. When you go, the second kind of risk is if there is any irritation because of the implants that you put in. The screw is irritating a nerve or because of dislodgement or whatever. So we minimize this again by doing intraoperative monitoring during surgery, meaning we monitor from your scalp to your arm and to your leg, and that helps us. We also have electrodes in the endotracheal tube that the anesthesiologist puts in. So when you're doing neck surgery, there is somebody reading this immediately, and if there's irritation, you correct it right away. So that's the other way that we try to minimize the complication. And the third potential risk is what we touched on, is that over time, you may need something done at the levels above or below.
Thank you, doctor. Really appreciate all the great work that you do. Again, if anybody has any questions, please put them in the chat and we will get to them at the Q&A portion of our discussion tonight.
Continue. Okay. So this is an example of an MRI scan of the neck. Again, this is the front, this is the back. And if you look carefully, you see the white signal in front and white signal in the back. The spinal fluid, and the dark structure here is the spinal cord. This is part of the brain here. So you can see here, the spinal canal is narrowed. The canal here has about the dimension of your little finger. So it's not a very big structure. And so when you have compression of the spinal cord here, that needs surgery. So this is the post-operative picture of the patient where they remove the bone and they put in here a device, which is a cage, which is filled with bone graft, and the plate and screws to secure it in place. This just shows the approach from the front of the spine as to how things are done. And part of the removal of the bone is where we need a drill, which is a high-power drill, which goes at 50,000 to 70,000 RPM. So one has to be careful, obviously, as we use it. Next slide, please.
Hey, doctor, this would unfortunately we are running into time, and this is super fascinating. But if this could be the last slide, please, we'll give you this last one here.
Okay, then skip this slide. Let's go to one more slide, I think. Keep going. Slide. Okay, so sometimes what happens is that in chronic pain, meaning patient has had surgery and they have what's called failed back surgery because they still have pain in spite of having surgery, then comes the treatment, which is called chronic pain therapy, where one of the modes is to put a spinal cord stimulator. It can be different kinds. Next slide. This is what it looks like implanted in the spine. The mechanism here is that you try to block the pain symptoms which are coming in from the feet going up to your brain. So you block them by this stimulator so the brain doesn't see the pain, so to speak. Next slide, please. The other way, when there's intractable pain, and this sometimes happens more in malignancy, etc., is that we implant a catheter which delivers narcotic directly in the spinal canal, and there's a pump there. So about every 2-3 months, you come in, you refill your pump, and the pain is controlled. You don't have to take medications by mouth. This is, of course, at the end in terms of having exhausted other modes of treatment. Thank you. That's all I have to say.
Oh, doctor, thank you so very, very much. A lot of great stuff, a lot of great information, and fascinating. And so I really do appreciate you taking the time to join us this evening. And I'm sure there's questions that we will be asking you at the end during the Q&A as well. Next, our speaker of ours is going to be Laura LaPalla. She is a physical therapist. She graduated from the University of Delaware. There she is. All right. She has a Bachelor of Science in Nutrition and Dietetics, MCP at the Hahnemann University, Master of Science in Physical Therapy, many licenses to include physical therapy, 2000 special training certification. She's certified in strength and conditioning, Institute of Orthopedic Manual Therapy, Level 1 fellowship. Then the list goes on and on. Some of her clinical interests include adolescent and adult orthopedics and sports manual therapy, pregnancy and postpartum dysfunction. Ladies and gentlemen, Laura LaPalla.
Thank you for all of that. You guys did your homework. That was so nice.
Oh, thanks.
Thank you, everybody who is here for sharing your evening with me. I'll just give a little bit further background. I have been a therapist for a long time. Sometimes I'm like, it's hard to say the years now. I don't feel like I'm that old, but you know, almost 25 years I've been a PT, and yes, I was a nutritionist before that. As much as I have various specialties, one of my main ones is treating the spine. And it's the number one diagnosis I currently treat in the clinic. And it's probably honestly the number one diagnosis that people come to physical therapy for. And I have treated veterans and active duty people of various military branches. And on a little bit of a personal note, my brother-in-law is a retired from the Army. And so through him, I have kind of learned on a little bit more of a personal level, you know, the chronic conditions, the chronic aches and pains that you endure long beyond your active duty service. So that's just a little bit of my personal relationship to this topic. So what is the role of the physical therapist? I'm just going to give kind of like a broad generalization of my role. Basically, my role is to work with you to establish your goals, and then to come up with a game plan based on what you think is feasible, what you think is reasonable, in order for me to help you get better and to figure out how to self-manage your symptoms. Like Dr. Numrel said, osteoarthritis in the spine is normal wear and tear. We're all going to experience it. But those of you that are, either veterans or still active duty, experience it at a much higher rate. And so that's a reason that you should not be ignoring your symptoms and know that there is help, and there is help beyond surgery. Like Dr. Numrel said, surgery is not the first line of treatment. And so I'm going to talk about some non-surgical management options that I do with my patients, and most physical therapists do with their patients. I'm going to talk about that a little bit in regards to 3 phases of pain and symptoms. So acute symptoms are typically those that you will experience from like 4 to 6 weeks. This group of people usually go to see their primary doctor, typically are recommended some type of anti-inflammatory medication, maybe a steroid medication, and are told rest and then kind of resume your activity when you feel like it. A lot of times this group of people will go see a chiropractor as well. If they happen to come see me, the first line of treatment is basically symptom management and behavior modification. And so I'm going to teach you maybe how to do some things differently so you can get through your home life, your work life, and maybe your community responsibilities without making your pain better. And so then it will typically, like I said, go away within those 4 to 6 week time period. The other group are the people who have surgery. And this can vary a little bit. So if you come to see me after surgery, and let's say maybe you're only 2 weeks post-operatively, that management will look a little bit more like the acute care group. So I will talk about your healing phase, give you an idea of how long it might take to be at an activity level that you would like to be at. Typically, we'll start with maybe some breathing exercises, some light exercise. If you have a protocol, meaning if the surgeon has decided he wants me to follow certain guidelines, I will work towards educating you and showing you what you can do so we stay within those guidelines. If you're somebody that's had surgery and maybe you come to see me months later, your treatment will probably involve exercise a little faster unless you're still experiencing some pain. And if that's the case, then we might have to talk about some behavior modifications and slow things down a little bit. So those 2 categories are very similar. Exercise, sometimes I'll talk about some other non-exercise based treatments once I talk about the next category. Chronic symptoms are defined as having symptoms for 3 months or longer. This is the group that definitely comes to physical therapy most often. This is, I would say, 90% of my population that I treat related to some type of spine OA that's coming in for physical therapy. And the difference with this group is that there's a mind-body connection education component that needs to be included, and I'll talk a little bit more about that in a minute. But exercise and movement is a big part of physical therapy for those of you that are experiencing chronic symptoms. And a lot of people with back pain, those symptoms are years. And like Dr. Numrel mentioned, there are some people that have surgery, but don't necessarily get better because it's considered a failed surgical intervention at that moment. And, those are the people that I see as well. And know that there's no one exercise program that fits all. There's no such thing as a bad exercise. There might be an exercise that's not good for your body in the moment, but there honestly is no such thing as bad exercises. And there's no such thing as a bad exercise for everybody. I think, with the social media nowadays and influencers that are on there, the things that people talk about is crazy. So you really have to, if you're somebody that follows influencers and are a big social media person, you really have to do your homework to know that you're actually following someone that has a good education talking about spinal conditions, spinal pain, and exercises related to that spine. So exercise, again, it kind of depends on where you are in your journey of life with chronic pain. So if you're somebody that comes to see me and unfortunately you're spending a lot of time on the couch, I'm not going to tell you to go walk 30 minutes every day. That is not realistic, and that's not going to set you up for success. So my first goal for you is to try to get you every day to wake up, get out of bed, and take a piece of paper and a pen or your telephone and write an activity goal. And one of those activity goals has to at least be walking. The research shows that people with chronic pain, walking is one of the best forms of exercise for you. And I might tell you, I want to walk 5 minutes once a week. That's 5 minutes more and one time a week more than you're doing currently. And then the other parts of exercise that we'll try to incorporate based on, again, your goals, what you're trying to get back to, can include strength training. That might be you going to a gym if you like the gym. That might be giving you some ideas of what you can use around your house. The other thing that people who have chronic pain related to spine OA experience a lot is stiffness, lack of flexibility, especially at your hips and your spine. So a big portion of getting you to feel better is teaching you how to move at your hips, and giving you some mobility at your hips. And the same thing at other parts of your spine. So that might include some movements that you do laying down. That might include some movements that you do standing. Again, you may love going to the gym. So then I'm going to teach you how to do things at the gym. You may hate going to the gym. So I'm not going to encourage that type of therapy if that's not something that's going to help you get better. And the other thing to know is that pool therapy can be very helpful. So if you have access to a pool and you're somebody that actually enjoys going to the pool, that might be a starting point and an adjunct to create an exercise program that you at least can do without pain. I think one of the biggest takeaways in regards to those of you that are experiencing chronic pain is that exercising in a way that makes your pain worse is not going to make you better. So it's not necessarily a no pain, no gain situation if you're experiencing chronic pain. The other forms of non-surgical management that are a little bit more passive and are not used long-term and are definitely not used alone, because the research shows that doing these things without also including some form of active activity or intervention, they're not very successful. So you may have some massage, you may have some hands-on where we do something called joint mobilizations to change the stiffness at your joints. Some therapists are trained in dry needling, so they may use that short term to help with some of your muscle pain or your muscle tension or your nerve pain. And then something that used to be utilized a lot more 20 years ago is something that's called TENS that some of you may be familiar with. And it's often not used in the clinic. We don't actually have one anymore because they're so easily accessible, either Amazon, pharmacies, your big box stores like Target. And just because we don't use it in the clinic doesn't mean that it can't be helpful to you. So sometimes I might have people bring in their TENS unit if they're adamant that the only way they can move is with that. Because again, the goal is movement. And if you need to use that TENS unit short term to get some moving happening, then fine. The other time it can be somewhat useful is during a flare-up. And I'll talk a little bit about that in a second. Okay.
So Laura, really quick. So you talked about walking, and ensuring that that there are safe exercises that people want to do. Are there any other specific type of exercises that are beneficial for people with spinal osteoarthritis to help maintain mobility?
Sure. So, and some of it might depend on your interest too. So again, it kind of depends on your body's pain response to exercise. So if you're somebody that enjoys biking and I can get you on a bike without your pain being exacerbated, if you're somebody that enjoys hiking, you might be a CrossFitter. You may have been a CrossFitter in the past and you've tried to go back to it, but your body isn't tolerating it. And so, hopefully my expertise and your ability to be honest and share what you're doing, we can come up with some form of game plan so that at least you can go back to your CrossFit gym and do some things that don't necessarily make you feel worse.
Thank you.
Is that all right? Okay. All right. So now I'm going to talk about pain management strategies. And I'm going to stick to pain management strategies geared more towards that chronic phase group, because honestly, this is the group that exists in large numbers, civilian based and military based. And that's that group that's 3+ months or longer that experience chronic pain. And more so than not, people that have had pain for years, people that have tried maybe even physical therapy and it hasn't worked. They've had surgery, it hasn't worked. They're on opioids that don't work, different forms of medication that doesn't work. And the big ticket item is the mind-body connection with this group. And I'll give an example in a minute. Basically, the mind-body connection is the notion that we cannot experience pain without the connection from our brain to our body. And unfortunately, when I talk about that, a lot of times my patients hear, it's only in your brain, it's only in your mind, I think you're crazy. And it couldn't be the furthest from the truth. Basically, what I'm trying to educate them about is the fact that if you're not taking care of your mind's connection, you're going to have a hard time getting your body's experience of pain to be lessened. And here's an example of that. Limb loss is one of the best examples of that connection. So if I happen to have an injury where I lose my hand, I no longer have that part of my body. And if pain was only part of your body connection, then I should no longer feel pain. If anybody's on the Zoom meeting tonight and you happen to have experienced a limb loss, you are very well familiar with phantom pain. And phantom pain is the experience of the fact that my brain still has the area that recognizes my hand and recognizes that my hand had a big injury, and it still sends impulses down my spine, basically to the area that my hand was, and I feel pain and I feel my hand. That's like the quick, easy way to explain that connection.
In closing, can you just tell us in your estimation what the success looked like for you?
Yeah, so the successes for me, I would say very, very differently based on those groupings. So when it comes to acute and the post-surgical, I think those people are in a better place. They are more likely to recover definitely at a faster rate. The people that are on the chronic phases, unless you're working towards your mind-body connection, you are doing some mindfulness, some meditation, you're working on your sleep habits and getting better and restful sleep. And then you also have, a plan for your flare-ups. All those things need to be incorporated in your physical therapy sessions. And when all of that actually happens, that's when the success rate is better.
Awesome. Thank you, Laura. There's some great information, and I'm going to put you on speed dial, by the way. So I'm going to get your information before we wrap up today. So thank you again.
Can I just add one other thing real quick? In the surveys that's going to come out to all of you, some of the references and the professionals that have really good podcasts and are really good resources for those of you that are struggling with chronic pain, please, please, please read that information that's going to come after this meeting with your email. And I highly encourage you to listen to the Rachel's Softness podcast.
Thank you, Laura. And please stand by. I'm sure there's some questions that are coming your way at the end here with the Q&A.
Sure.
Our next speaker, let's see, where is he? Is Coleman Nee. Coleman Nee is a veteran of the United States Marine Corps and a Gulf War veteran. He is a life member of the Disabled American Veterans, the DAV, of Chapter 3 here in the Department of Massachusetts. Coleman currently holds a position of National Senior Vice Commander. He has served on the National Line of Officers for 4 years and is a former member of the DAV Board of Directors and Interim Legislative Committee. interim. Until recently, NEE has left Triangle Inc., which provides support to the disability community, youth, and adults with innovative career leadership and safety skills they need to live more independent and dignified lives. Prior to this, he served as the Massachusetts Secretary of Veteran Services from 2011 to 2015. He is a Boston native and graduate of the American University in Washington, D.C. He has close to 30 years of veterans advocacy, governmental, not-for-profit, and private sector management experience. He is committed to human services and civic engagement for the veterans community. He currently lives in Cape Cod, Massachusetts, with his wife, Karen, and a very good friend and a dear friend of mine. So, ladies and gentlemen, Coleman Nee.
Thank you very much, Commissioner, and thank you, Doctor. Thank you, Laura, for very fascinating talk. I feel like you know, you're going to hear from the least smartest person on the call right now, but I'm just going to give quickly a little bit of some info, which I think is important. You know, particularly to those, not just the veterans that are on the call, but to everyone that's on the call, because you may be the spouse of a veteran, or you may be you may be the parent of a veteran or the friend of a veteran, or there may be an older gentleman or older woman that lives on your block who, you know, has a flag in their yard, and you think that, you know, they served in the military. All of these people are eligible for benefits that they probably haven't accessed. So not only would I encourage all of you to access your veterans benefits, but to also be on the lookout too for other veterans, so we can get everybody hooked up with what they've earned, and keep their lives healthy and focused and living to the fullest. My organization that I'm representing, DAV, I represent on the national level. I know the partnership is here with DAV of Massachusetts, which is our state department here in the Commonwealth. But Arthritis Foundation has strong connections with the VA, as well as and is making other inroads with other DAV chapters and departments throughout the country. And this is important. I mean, I'll tell you a little bit about who DAV is, then I think you'll realize why it's so important. You know, DAV basically is a nonprofit that provides a lifetime of support for veterans of all generations, their families, and their survivors. Now, every year, excuse me, our no-cost benefits, and we are a not-for-profit organization congressionally chartered by Congress. Every year, our no-cost services help nearly 1 million veterans access the benefits and health care that they've earned, while connecting them with meaningful employment, and as well as representing their voices, our voices, on Capitol Hill. And as the leading I would argue, the leading veteran service organization in our country today, we focused on keeping the promise to America's veterans for more than 100 years. And how do we do that? Well, one of the things we do is DAV is your conduit and your guide to accessing your benefits, particularly at the federal level. If you, the commissioner can tell you, if you go to the VA site and try to file a disability compensation claim on your own, or you try to do anything more than just sign up for healthcare or something that's going to require some type of process and adjudication, you're going to want someone in your corner who's helping you along, and somebody that knows that process and someone that knows that system. And that's where DAV really comes in. All of our national service offices are located at VA centers where they do these benefits. We're across the country. We process a tremendous amount of claims for our veterans. And again, you don't have to be a DAV member to take advantage of this, and this is a no-cost service to you. So I really want to encourage you, for those of you that are seeing attorneys' ads on TV or things claiming, you know, if you're a veteran, give us a call, we'll help you out. Well, they don't help you out for free. They take a third of whatever your benefits check is at the end of the day, whatever your retro benefits are for your disability, and then they kind of set you off. DAV is actually the opposite. We don't charge you for anything. You don't have to be a DAV member, and frankly, we're better qualified to do the job because we're actually in the VA, and it's really one of our core competencies of what we do. So please, if you haven't heard of DAV, I would ask you to go to DAV.org. If you're here in Massachusetts, DAVMA.org. Make sure you get information. We'd love to have you join us. We'd love to have you be part of our ranks. There's a lot of benefits and a lot of services that come with that. But more importantly, we want to make sure that you get everything that you've earned and that and especially around your health and your financial situation. So when it comes to the VA, people ask, well, how do I get into VA? Well, VA has been, for a long time, was very exclusive for veterans, to be able to get care. And that has really changed in a huge way. And now we're back to the situation where VA is being very open, and a lot of veterans who previously might not have been eligible for VA care, and there may be veterans on this call who tried to sign up for VA care. Try again, and you don't have to go anywhere. You can sit right in front of your computer. Go to www.choose.va.gov. Chooseva.gov. If you go to that address or you look that up, you're going to find that you'll be able to get online application and tell you if you're determined like how to get enrolled in the health system, which is great. And then they'll assign you with the primary care if they enroll you. And I would really strongly encourage, particularly here in Massachusetts, using VA services if you're comfortable with that. Many of the VA docs that work here in Boston, I know the commissioner can tell you, VA is my primary care. Now, I can afford. I have been fortunate enough where I have other healthcare choices that I can make, but I actually choose VA because I find it better. Number one, there's no risk managers in VA, so I don't deal with a healthcare plan. I don't deal with someone or an actuarial who's looking at my data and whether I'm worthy of saving or not that month because of my life expectancy or whatever. It's really, you get the care that you need when you need it. And two, it opens up a lot of benefits to you, and many of those are no cost. So I would really encourage you to see if you're eligible. If you are eligible, enroll. It's free. You don't have to use it. You can still use your private healthcare insurance. As far as arthritis goes, I don't think I have to tell anyone here on the call that's ever served in the military the very varying things that we experience on a daily basis that have excess strain on our joints, on our backs, on just about whatever. Whether it be ill-fitting equipment and you're humping a lot of gear on your back. It could be, riding in military vehicles, which were designed for many things, but comfort was not one of them. And certainly they didn't splurge on shock absorbers on many of the trucks and transport vehicles that we were transported on. And and just finally, there's just a whole bunch of issues related to toxic exposures and other things that really VA has studied and they can see. In fact, in 2015, VA did a study on PTSD and arthritis and found that those with post-traumatic stress had a tendency to suffer arthritis more as a result of that stress, and that's on its own without any accompanying other sort of big issue or accident or movement. So it really is. It really is beneficial. Now, if you have arthritis and you believe that you can connect it to your service, you can file what's known as a claim, and they will provide you with, and DAV will help you with this. Again, no cost. You're not obligated to go to DAV. You can go to other vet service organizations. You go to Rob's office or the Department of Veteran Services for the state, Executive Office of Veteran Services. But we're here and we're a partner, and we do this work pretty well. What we're going to find out is get medical records. We're going to have to establish either from your service records, your medical service records, that you showed muscular or joint discomfort while you were in service, or afterwards that you've developed this disease And it's quite probable that that some contribution to that came from your military service. So, there'll be CMP exams, there'll be range of motion exams that they'll give you. We'll go through all of that with you. But there are also presumptive conditions as well. And I can wrap up on this, Rob, and get to the Q&A. For presumptive, it just basically means that if you either served in these areas or have these certain issues, and you then develop arthritis, the VA has enough data to be able to presume that your arthritis in some way was caused by, and to some degree, whatever the other condition is. So right now, for presumptive conditions for arthritis, if you're a prisoner of war, it's presumed that your arthritis was caused by your captivity. Do you have any chronic debilitating diseases? Did you have any tropical diseases? If you served in Vietnam, and welcome home if you did, were you exposed to Agent Orange? And, and if you served in country in Vietnam, you probably were, or it's probably presumed that you were. Any asbestos exposure? My Navy friends will tell you there was a lot of asbestos on Navy ships for a very long time. And it wasn't covered up. It was sprayed on boilers and pipes and everything else. And a lot of naval veterans come up with borreliosis and asbestosis, and these are arthritis can be a secondary issue from that. Radiation exposure, mustard gas, or any type of gas or toxic exposure. Did you serve at Camp Lejeune before December of 1987? If you did, you had water exposure to toxins in the water. That is a presumptive condition for arthritis. Do you have Gulf War syndrome? If you served in the Gulf and you have chronic fatigue, irritable bowel syndrome, chronic headaches, respiratory issues, any of that, that's going to be a presumptive condition. Or if you're around burn pits or any particulate matter exposure, then the VA is going to presume that your arthritis was caused from that. So the three things, if you're interested in this, to do are one, to look at, get on that VA website tonight, find out if you're eligible for VA healthcare. Two, even if you're not eligible for VA healthcare now, maybe explore DAV, look to our national service reps, reach out, have a conversation with them, tell them you want to file a claim. And again, they will do all of the heavy and legwork for you. For the most part, you'll have to get a couple of documents for them to be able to move forward, but they can help you find those as well. And third, please, if you do get access to care and you have used a DAV rep for your service, or even if you haven't, I would ask you to look at DAV and the slate of services and benefits that we offer to veterans and their families, and consider joining DAV. We're one of the least expensive life memberships of all the vet service organizations, and we're also one of the most effective. So with that, Rob, I will turn it back to you. I know we're running a little short.
Yeah, thank you, Coleman. With a lot of great information, and a lot of the presumptives that Coleman is talking about, are new to the VA as well through the PACT Act that was signed by President Biden. So at this time right now, I am going to turn it over to back to Erica so that we could start our Q&A. Erica?
Thank you. We got some really great questions in the chat. So if Laura and Dr. Namel will come back on screen, because some of these are for a mixture of the lot of you.
I can't go back on video, sorry.
Oh, okay. But you can come off mute.
Yeah.
Are you okay? Great.
The host that's on video just told me.
Oh, okay.
I'll
the host will.
Oh yeah, here we go. Yep.
There you go.
Okay.
And Dr. Namel, if you want to come back too. So here are a couple of questions that we got from the Q&A. The first one that we got was, why do muscles hurt when you have spinal osteoarthritis? I don't know if Laura or Dr. Mel wants to take this one, but
I think Laura may be able to answer that question better. But remember, muscles attach to your bones. Muscles move your bones. So if you got pain related to arthritis in your joints, your muscles are going to hurt also. You're going to have limited motion. But as I said, I would defer to Laura because I think she probably can tell you a little bit more. She lays hands on people.
So one of the things that is a good thing about our body is like its protection when we do have high levels of pain. And when it comes to spine pain, one of that way that we protect ourselves is those muscles will guard and protect you. And so some of that soreness can come from that guarding. And similarly what Dr. Nirmal just said, so if I have pain in my back, I might move differently too. And if I'm moving differently because my back hurts, then sometimes I'm using the muscles very differently. And so that's another reason that the muscles can have some soreness or pain to them.
Thank you so much. I think this one is for Dr. Dermel specifically. I have brachial plexus since July of 15, and I'm still having ulnar median nerve numbness and pain. How long do you wait to have surgery to fix the compressed nerves?
Okay, so I mean, these two separate issues. Is it a brachial plexus injury or is it a specific injury related to your ulnar nerve or the median nerve? So if it's a brachial plexus injury, that's a much more complex task. And the idea there would be to try to see what can be corrected if there's compression or bleeding in that area. In terms of the specifics, for example, if you have numbness or weakness related to your ulnar nerve, the ulnar nerve would supply typically the ring finger and the little finger where you would have the numbness. And most often the cause is because of compression at the elbow where your funny joint is, funny bone is. That can be corrected. Surgery often will help significantly. If there's median nerve problem, that will give you symptoms of numbness and or pain at the wrist and primarily in your thumb, index, and middle fingers. Again, the initial treatment is a brace. You can have an injection of steroids. And if that doesn't work, you can have surgery. It's an outpatient surgery. And usually the results are excellent in terms of relief of symptoms.
Thank you, Dr. Normal. So the next one, Iraq war veterans wear 40 to 60 pounds of body armor combat load. Do they have higher risks of DJD symptoms of the spine than non-combat veterans? I don't know who wants to field that one. Yeah, Dr. Normal shaking his head, yes.
Yeah. Absolutely. As I said, we've treated some veterans too. They're young. They're generally very healthy. They are good muscular, but they have pain because they have suffered significant trauma. Paratroopers, carrying heavy weight, and as was mentioned, riding in vehicles which are not designed to be comfortable necessarily. So yes, this is not an uncommon problem. We see this often in veterans who are in their 40s, 50s. And as you mentioned before, we are seeing more female people who served in the armed forces.
Yes.
Thoughts on Dr. Normal, I'm not going to get it. Intraosseous PRP injections versus steroid injections, growth factors to heal the inflammation area. I know I didn't get that right, but you know what I'm talking about.
So, people generally use steroids, which is the typical thing that is given in the epidural space in the spine. People have tried, plasma-rich protein extracts to inject either in the disc or directly in the spinal canal area. And there seems to be some greater benefit, perhaps in terms of how much longer the pain relief may last. But bottom line is, if the treatments work for you, then that's the right thing to do. I absolutely agree that conservative treatment, non-surgical treatment, first exhaust all of that. If that doesn't work, then surgery is something in selected specific cases with specific indications that it should benefit. And making sure that generally speaking that you're getting surgery with minimally invasive technique will make your recovery a lot faster.
Wonderful. I don't want to put you on the spot, Laura, but this one is interesting. Is chiropractic treatment safe and effective for people with spinal osteoarthritis?
Yes.
Laura, do you want to take that?
Yeah.
Sure. It is. It kind of depends on, so like I do some manipulative chiropractic movements. There is a definite guideline that we all should be using related to your symptoms, possibly some imaging if we have access to imaging. There's risk to everything. There's risk in the neck. There's risk whether it's in the middle of the back and the lower back. And I think if you choose to go the chiropractic route, whether it's with your physical therapist or a chiropractor, you need to make sure that the person if stops if you don't feel comfortable. They should be talking to you about, do you have headaches, checking your blood pressure, some signs and symptoms that might lead to them not manipulating your neck. If you have really severe changes to the neck and you're having, your images showed, big, Dr. Mel kind of talked about lethus, where it's, you have a change in how the alignment of the bones are. There's some levels of severity that it could cause more harm than good. And yeah, but there's definitely people that benefit from it who have arthritis.
Coleman wants to
Yeah.
say something.
Yeah, Eric, I thank you very much. I just wanted to chime in on two things. First, with Dr. Namel, in terms of the women veterans that he mentioned. So, women veterans are the fastest growing segment of our veterans population, and we were talking about this before on the call. For DAV has done a significant amount of research on women veterans, and if you go to the DAV.org website, you can find a number of reports that we filed with Congress. But one of the things that we know for sure is that for many of the women who were deploying, particularly to Iraq and Afghanistan, the equipment was not designed with gender in mind. Many of us ended up with equipment as males that didn't fit us. And so there's a significant amount for women veterans in particular. There is probably a significant amount of people who are going to, having used that equipment, found that it's really caused them some problems from a musculoskeletal standpoint. And then as far as alternative treatments go for arthritis, I know one of the things that I've been really psyched about, at least with VA, is that they've really embraced everyone from chiropractors to acupuncturists to Tai Chi to yoga. So there's a lot going on there. And in fact, VA last April opened a new center out of the Philadelphia VA. I'll have to read this name to you because it does not roll off the tongue, but it is the Cartilage Regeneration Using Advanced Technologies to Enable Motion Research Center. I guess that the acronym is CREATE. But one of the things people don't know about VA that is a huge mission of theirs is that VA does a tremendous amount of research. And when you're using VA, you're in the world's largest integrated healthcare network in terms of computers and research and stuff is there's a lot of data there that they can draw from to look at research. So they are looking at alternative treatments to surgery and to other things. Obviously, if you need the surgery, you have to have the surgery. But I'm sure most people would prefer to at least try other things first to see if it helps. And there's a lot of options there. So we really encourage you to please go to va.gov and see if you can sign up and again contact us because we can help you navigate that system.
Actually, that's a perfect way to end this because we're done with our Q&A. I want to thank everybody who put some really thoughtful questions in the chat. And it was really a robust. They were starting from the moment we began. Robin, will you pull back up the slides for us? Commissioner Santiago, do you want to say anything in parting before I give the final synopsis?
No, this has just been an amazing webinar, and I truly hope that many people that couldn't be on the webinar tonight will take time to actually view it. I know we're running short on time, and it pained me to, I had to have, needed to move on because of time, but a lot of great information. And, just to echo one of the last comments from Coleman is, women are the largest growing population in the veterans community. And there is a big focus in the VA to ensuring that women get the equitable care that they get as well. So, this has been a great webinar, and Erica and Jasmine and the team at the Arthritis Foundation, thank you so much for giving us the opportunity to also discuss what goes on in the veterans community and the military community as well.
Thank you so much, Mr. Santiago. And I want to say thank you to all of our panelists. You guys were incredible. I probably could have spent another hour listening to everybody talk about this stuff. Up on the screen are some upcoming events and resources for everyone. This will be emailed to everyone in the post-event survey, as well as the resources that Laura mentioned. I know that Robin put them in the chat. They will be reiterated to you in the post-event survey. So please take the time to open it up, and please feel free to pass this along as well to anyone that you think would benefit from it. And then if Laura will just go to the last slide. I'm sorry, Robin will go to the last slide. Sorry, Laura, I was looking at you. We really want to thank our sponsor for tonight, which is Johnson & Johnson. They were incredibly grateful to them for being so generous to us and helping us put on this type of programming. And of course, our community partner, the Disabled American Veterans. I can't tell you how wonderful this partnership has been over the last 3 years, and we are expanding it across the country, and we could not be more grateful. As we know, this is a population that needs additional resources and access that we hope, as the Arthritis Foundation, we can help to provide. So thank you to all of our panelists. Thank you to all of you who have joined us tonight. There will be a recording posted on YouTube, and have a great night, everybody.